patient has moderate to severe COPD exacerbation. That means a patient will have, for example, 2 or more symptoms, which can be dyspnea, or for example, if patient has increased dyspnea, or sputum volume or viscosity is increased, or if purulence of sputum is increased. So dyspnea is increased, purulence or volume or viscosity of the sputum is increased. And then we can say that it is a case of moderate to severe COPD exacerbation. And what happens after that, if the person has that, then what happens is we can either these things are present or these things are absent. If it's absent, then antibiotic treatment is not given unless patient's symptom worsen more. And how will you tell that patient's symptoms has worsened? You can say by two things. For example, if the bronchodilator requirement use has increased, or if systemic glucocorticoids you were giving, for example, in COPD we give 40 mg per day for 5 days, or by American Thoracic Society what they advise is 125 mg the dosage. So dosages differ. One guideline will say 40 mg per day for 5 days. American Thoracic Society will say 125 mg is the dosage of the steroids. Or if bronchodilator requirement increase in moderate to severe COPD patient, and then we give antibiotics. Otherwise, if patient is not moderate to severe COPD and patient's bronchodilator use requirement it increases, then we start him on antibiotics. Whenever we start antibiotics, we have to evaluate the clinical response in approximately 72 hours. And antibiotic regimens that are usually to target the most likely pathogens for these exacerbations, which are Haemophilus influenzae, Moraxella catarrhalis, and Streptococcus pneumoniae. These three pathogens are the most likely cause for exacerbation. When we classify COPD into moderate to severe COPD exacerbation, and we see thereafter whether the patient has got poor outcomes or not. So for poor outcomes, we have following things. For example, FEV1 greater than 50%, or if the patient has greater or equal to 2 exacerbations in past 12 months, and if he receives oxygen support continuously, or if he has any other comorbid conditions, or if age is greater than 65. So these are the risk factors for poor outcomes. If he fulfills any criteria among these, then we see other things like whether there has been any isolation of Pseudomonas from sputum in the past 12 months. That can be yes, or that can be no. So if it's yes, then we initiate treatment against Pseudomonas, which is we use Ciproflox, and thereafter we start antibiotics as per culture sensitivity. So you have to take sputum cultures for to tailor the antibiotic needs of the patient at that time. So use Ciproflox. And if patient does not have any evidence of Pseudomonas colonization or Pseudomonas isolation from sputum within the past 12 months, then we further see whether he has any risk factors for Pseudomonas infection. So previously we used to see only in words 3 things, that we have local epidemiology suggesting Pseudomonas infection, or broad spectrum antibiotic use within the past 3 months, and if uh, a patient has underlying comorbid conditions like bronchiectasis, if patient has, or if patient has been using these systemic glucocorticoids uh, or FEV1 less than 30%. You see, chronic glucocorticoid use as per American Thoracic Society for COPD exacerbation can in turn uh, through the patient towards Pseudomonas infection. So patient can catch this Pseudomonas bug if we go according to ATS protocol, which suggests using high dose steroids like 125 mg. Although efficacy has been same, that has been with 40 mg per day or as 125 mg per day. So steroid usage by both recommendation has been up to this 5 to 14 days at max. It reduces hospitalization, although there is no mortality benefit uh, when both these regimens are compared. So here, if patient has other risk factors for catching these Pseudomonas infection, then what we see is uh, we initiate the patient's treatment according to uh, the suspicion that he has Pseudomonas. We use ciproflox or levoflox, and if these factors are not fulfilled, then what we do is we use either amoxiclav or we use another respiratory fluoroquinolone, levoflox or moxiflox. So using amoxiclav is not bad, but if it is used, it is to be used when you have ruled out every possibility, uh, every case scenario in which Pseudomonas infection could have been the cause for this exacerbation. So if we go back, so here we went to two possibilities. Here we'll see the patient poor outcome is present, then we saw two things. So if patient has poor outcome or not, so either possibility was yes or no in case of moderate to severe COPD exacerbation. If poor outcome was present, then we use it to see whether Pseudomonas infection was a possibility or not based on objective evidence. For example, if he has grown culture, if cultures have grown this Pseudomonas infection within the past 12 months, or if there has been a chronic Pseudomonas colonization. So that was objective evidence, or if we could indirectly get any evidence for Pseudomonas infection, for example, FEV1 less than 30% or comorbid condition like bronchiectasis or broad spectrum antibiotic use within past 3 months or chronic systemic glucocorticoid use. But if poor outcome was absent and patient has moderate to severe COPD exacerbation, then what we use antibiotics based on patient's characteristics or prior antibiotic usage. For example, we can use here in this case scenario, we can use either macrolides, for example, azithromycin. We can use second or third generation cephalosporin. For example, we can give cefuroxime, we can give cefodoxime or cefdinir, and post which you see whether after 72 hours patient's clinical symptoms have improved or not. If it has improved, then what you do is you continue the therapy for this 3 to 5 days. If it didn't improve, then you obtain sputum, gram stain and culture. Then you tailor the antibiotics as per reports of those this culture and gram stain tests. What happens sometimes, these macrolides or cephalosporins cannot be used. Like if this is the case where a patient develops allergy or there are other adverse effects, then you can switch to this trimethoprim sulfamethoxazole. You see, the antibiotic usage is to be done in a smart way. For example, we know the three most common pathogens that lead to these moderate, severe, or these COPD exacerbations are Haemophilus influenza, Moraxilla catarrhalis, Streptococcus pneumoniae. What we do is we know Ciproflox uh, targets mainly Pseudomonas, but Levoflox, it has although less activity. Ciproflox, for example, has this much activity against Pseudomonas. Levoflox have got only this much activity against a Pseudomonas bug, but it has greater activity against this Moraxilla catarrhalis and Streptococcus pneumoniae, which are the most common bugs causing COPD exacerbation. And thus, in patients in whom you suspect that they are at increased risk of this Pseudomonas infection, but when you do cultures or when you find objective evidences for that Pseudomonas infection as the likely cause, uh, you don't get the results that favor Pseudomonas infection. So objective evidence is lacking, but you suspect Pseudomonas infection is there. Then in that very case, you can use levofloxacin, targeting Moraxilla catarrhalis and Streptococcus pneumoniae. So thanks, this was the empirical antibiotic management for treating moderate to severe COPD exacerbation.